Hello, this is Sensory Alterations for Nursing 201. We're going to look first at the eyes. Anatomy and physiology review, we'll review that quickly. We'll look at the layers, the refractive structures, that's what's involved in making sure the picture lands on the retina. Your external structures, which are your mucous membranes, like your conjunctiva, and that's an excellent place to check for dehydration in your patients. The eye muscles, those need to all be working together in order for your eyes to have a single picture. If your eye muscles are not working together, that's when you get double vision. The nerves, you have cranial nerve 2, which is your optic nerve. You also have the ocular motor, which is cranial nerve 3, cranial nerve 4, the trochlear, and cranial nerve 6, the abducens. Those are all involved in eye movement. And the blood vessels in the eye, which is your ophthalmic artery. So looking here, the layers of the eye, you have the sclera, which is the outer white part of the eye. You have the cornea, which is the clear coating. You have the iris, which is where the color of the eye is. The retina is where the vision or the picture needs to land, that gets bent by the lens and the cornea, bent to land on the retina. If it lands in the right spot, then you have clear vision. You have the optic disc right here, which is the blind spot of the eye. And it's called the blind spot because you only have nerve fibers there, no photoreceptors, no rods or cones there. We also have the canal of Schlemm over here, which is when you talk about open and closed angle glaucoma, that's the canal you're talking about. The fluid that's inside the eye is more like a gel. That's called the vitreous humor. And then you also have other fluid that goes throughout the eye. That's called the aqueous humor. Vision, meiosis is constriction. Mydriasis is dilation. Accommodation means keeping a clear gaze from distant to close. Like if you're driving your car, you see a cop, you're looking at the road, you see a cop, you have distant vision, you look down to see how fast you're going. That would be accommodation, maintaining a clear visual image from distant to close. And then you have refraction, which is the bending of the light. So if you go to the eye doctor and you have your eyes dilated, what kind of drops are they using? That would be mydriatic drops. Diagnostic test, slit lamp is the traditional eye exam at the optometrist office, where you put your chin in the machine, then he uses the different lenses to examine your eyes. Corneal staining is if a person comes in with some type of trauma to the eye. They will use something called fluorescein blue. You put that with a little bit of normal saline into the eye, shine the black light. If you see a line, then you know that there's a trauma on the cornea. Tonometry is how you check the pressure of the eye. You deaden the eye with a little antiseptic drops. Put the tono pen on the eyeball itself and check what the interocular pressure is. It should be 10 to 21. Ophthalmoscopy is using the ophthalmoscope, the thing in the doctor's office next to the otoscope, and it is where you can look and see red reflex, which is of course a reflection of the retina. You should also be able to see the veins and the arteries, the optic disc, if you know what you're looking for. Most of the time what you're going to be able to see is the red reflex, and of course you need to turn the lights off in the room to dilate the pupils in order to be able to get any kind of vision in there. Ultrasonography, they use that sometimes if patients are worried about having some type of tumor or to see the fluid inside the eye. Fluorescein angiography, that's where you're looking to see the blood flow through the eye. Electroretinography graphs the retina's response to light stimulation. Why do people have visual impairments? You can get a perinatal or a postnatal infection, which we know chlamydia is the leading cause of blindness in the world. You can have retinopathy of prematurity, which is common in premature infants, especially those that are low, very low birth weight infants. And the key is oxygenation. You want to make sure the infant stays oxygenated but not over oxygenated. That can cause damage and the rupturing of the tiny blood vessels. You can have trauma, unknown cause. Systemic conditions and disorders. So what do we know is the leading cause of blindness in the United States? Diabetes. Hypertension can also cause visual impairments. And then some drugs are dangerous to the eyes. Nursing assessments. When do we check people's vision? In infancy, we want to make sure they can respond to stimuli. So you get something like something red or something that is shiny, move it in front of their face, and then move it around and see if they try to follow it. If the parents say, my baby doesn't seem to be watching me, you expect binocularity by 6 months. That means that their eyes should be moving together. Up till 6 months, their eyes are all over the place, but at 6 months they should be moving together. In childhood, you get visual acuity testing, usually every year at elementary school. You also want to assess a person's vision if they have trauma or accident. That could be using visual acuity testing like a Snellen eye chart, or if it's an emergency situation, just asking to how many fingers am I holding up? Or if a person says, my eyes were good yesterday and they're bad today, definitely need to assess their visual acuity. If a person is 20/70 to 2200, that's partially sighted. You are considered legally blind if you're 2200 or less. So if that number 200 gets bigger, that's worse. That means I can see, a normal person can see at 200 feet what this person has to be standing at 20 feet to see. What is the removal of the eye called? When you have an artificial eye, that's called an enucleation. When do people get their eye removed? Usually that is if they have some type of trauma, like a laceration and their eye pops out, or some type of cancer or melanoma of the eye. How do you care for the artificial eye? You can review that. That's on a chart in your textbook. We have a very quick video here. Okay, so there was a person taking out their artificial eye and putting it back in. Make sure that you would, of course, put gloves on. You want to use some normal saline or eye drops and store the artificial eye in saline. Just like I said, review that chart. Make sure you know how to take care of an artificial eye. So what do we need to do to help a patient with reduced vision? We have communication issues. We want to make sure that we tell a person, I'm about to touch you, I'm doing this. Make sure that they know when you come in the room where you are, clearly communicate what you're doing. Also, there's things like talking clocks and things like that that can be used to help a person in their home. Safety is very important. A person is more safe in their home than anywhere else. But when a person is admitted to the hospital who has problems, who is blind or has low vision, we need to sort of take them on a tour of the room, let them feel around, feel where the bathroom is, where the table is, where the bed is, so they know how to safely get around in the room. And we also want to let them know that they need to call and ask for help to get up, but still do the tour in case they need to get up and nobody's there. People are going to get up one way or the other, so we want to keep them as safe as possible. Ambulation, to help a patient ambulate who has low vision, you want to stand slightly in front of them, beside them, slightly in front of them, and let them hold onto your elbow, your bent elbow, and then that way they can easily feel you move. If you move up or down, it's a much safer position. So you want to stand next to them with your elbow bent and let them hold onto your elbow. Safe care, we want to promote independent living. If they're losing their vision, give things in big bold letters so they can clearly see it. And then support, let them talk to other people who have had vision loss or have lost their vision and how they deal with things. It's very important. to let people know that they can still maintain some independence. Primary prevention for visual impairments, prenatal care, rubella immunizations, because rubella causes blindness and deafness. So rubella immunizations for children. You also want to immunize adults to rubella, but that must be done prior to pregnancy, because if a woman catches rubella when she's pregnant, there's a very good chance either the pregnancy will be not successful or that the child will have severe birth defects. We wanted to safety to prevent eye injuries, wearing eyeglasses when you're outside, safety glasses, safety goggles when you're doing anything like cutting the grass, other things where you could get some damage to your eyes. And then disease control. It's unlikely for you to go blind from diabetes if your blood sugar is well controlled. It's unlikely for you to go blind from hypertension if your hypertension is well controlled. So patients with these chronic diseases, it's important that we keep those under controls and let them know the importance of keeping their disease controlled. Secondary prevention, when do we see how the people's eyes are doing? Prenatal, newborn through preschoolers, anyone who complains of eye problems. Adults, you want to get an eye exam every other year until the age of 40, and then you want to get an eye exam yearly after that. If you have an eye exam or eye problems, whether you're a child or any age, you need to get your eyes checked every year, and the elderly need to get their eyes checked yearly. That's all for the